Hello, JMIR followers. This is Dr. Jennifer Joe. I'm the JMIR ambassador, and today I'm interviewing Professor Dr. Tricia Greenhalgh. Dr. Greenhalgh is a professor of primary care health services and fellow of Green Templeton College at the University of Oxford. She studied medical, social, and political sciences at Cambridge and clinical medicine at Oxford before training first as a diabetologist and later as an academic general practitioner. Trish is the author of over 300 peer-reviewed publications and 16 textbooks. She was awarded the OBE, am I pronouncing that right? The OBE for services to medicine by Her Majesty the Queen in 2001 and made a fellow of the UK Academy of Medical Science in 2014. Welcome, Dr. Greenhalgh. I do have a question about the OBE for Services for Medicine Award and meeting. Did you meet the Queen? Can you tell us about this?
That was a very long time ago. I did meet the Queen very briefly, and I went to Buckingham Palace and put my fancy clothes on. And really, it was for committee work. I have to say, there's a lot of committees, and if you sit on enough committees, you get to go and meet the Queen. It's a sort of old-fashioned quirk in the UK.
Oh, I love that. And I think that was just an interesting piece of your really long and illustrious career. So congratulations on the paper that you published with us. There are three major topics of impact that I took away from your paper because you communicated so much. So I want to talk about first the video services in Scotland and the scale up in response to COVID. So that's obvious, that's the name of the paper. And then I also want to better understand the PERCS framework, or planning and evaluating remote consultation services. And finally, the lost art of, I don't know if it's lost, but stories and capturing stories is an important part of understanding technology and meaningfully incorporating technology and scaling technology in healthcare. So to kick it off, why Scotland? What was so interesting about Scotland, and why a national case study?
Okay, well, for the international readers, Scotland is at the top half of the UK. So you've got England on the bottom, and you've got Scotland on the top, and then you've got Wales over in one corner, and Northern Ireland, of course, across the sea. So there's a part of Scotland called the Highlands and Islands, and that's in the north and also kind of across the sea on little islands around the top of the UK. And it takes a long time to get to those places. And of course, you're at the mercy of the weather. We drove all around Scotland doing some field work, and sometimes we got stuck and we got cancelled and had to check into a hotel until the weather was better. Then we could get on the boat and go across. So it's important to understand that Scotland, a little bit like Norway and maybe parts of Canada, were geographically perhaps quite well suited to telemedicine, and other kinds of remote services, remote social care services, remote libraries, all that kind of thing, because of the geography. Now, the Scottish government invited us to bid for, we weren't the only ones who were invited to bid, but we were the successful bidders for a contract to evaluate remote services before the pandemic. And we finished our fieldwork for that in November 2019. Which is quite serendipitous because the pandemic began a couple of months later, but we had very detailed fieldwork data, and we were just writing up our report to recommend to the Scottish government that they should continue to expand along the same trajectory as they had begun, because we found a very positive, particularly in some pilot settings, in some parts of Scotland where they'd put a lot of resource and they were effectively developing demonstration projects and programs. And so our report, which was delayed slightly because of the pandemic, where we said, yeah, this is good stuff. You're not doing everything perfectly, but most things you're doing really well, and it looks like it's going in the right direction. So please carry on. So overtaking that, the pandemic happened, and then suddenly every country in the world was saying we've got to do remote consultations, because of the risk of infection. So we then went back a few months later in the summer of 2020, doing all our research remotely this time. Of course, we couldn't drive around because we weren't allowed to, but we talked to a lot of the people that we'd already interviewed a year previously. What's happened since the pandemic? How did things go? And we also interviewed the technology suppliers and some patients, all that kind of thing. And also used data collected by the Scottish Government on things like the number of consultations done by video, for example, and what patients thought of it. They'd already embedded a little satisfaction questionnaire. So after every consultation, the patient was asked, how do we think this went? And we'd added in some clinical questions like, do you feel like you're better able to manage your illness now? All that kind of thing. So we had loads of data. And the great thing was, as we say in the paper, this was an example of what they call appreciative inquiry. David Cooper-Ryder's work on appreciative inquiry. Find something where most things went right, where it's basically a good story, and then ask, what was it? How come everything came together in a good way? And that's what we did. So as opposed to most studies of remote stuff or healthcare digital initiatives, where something usually goes terribly wrong and you think, oh, right, we're going to have to analyze that. But actually, nothing major did go wrong. It's a great story of, yeah, the world could learn from what Scotland did. And I think one of the key messages about Scotland was they did the groundwork. They had invested in not just the technical infrastructure, but that was important. They'd supplied broadband to all these remote areas. They'd done a lot of training. They had engaged staff, patients, policymakers, bureaucrats, got them buying into the narrative that this will be a really good idea. And it was linked to a kind of green agenda, a cross-government carbon reduction agenda. Let's stop people driving around, flying around to get to their medical appointments. So that was the groundwork. And they also had these very detailed pilot projects which were really up and running, and remote, particularly video consultations, were business as usual. And then the pandemic hit, and then they were able to, as I say, hit the ground running and say, right, we've got to roll this out, we've got to scale it up. And they did. They did within the space of about 3 weeks. The whole of Scotland went over to remote. It was amazing.
Beautiful. Thank you for sharing that. So there's a lot of learnings, and I really think we just have to someone has to read the paper, do a deeper dive, really live with the paper to learn all about that. I want to talk about the PERCS framework. It's a novel framework that really just resonates with me, and I want people to really understand what it is, why it's important, and why it might be useful for them when they're planning and evaluating remote consultations. So could you talk about this PERCS framework and kind of, we'll take it piece by piece.
Well, I know that the last thing you want me to talk about is telling stories. And so the PERCS framework is really a way to a sort of set of sensitizing areas to think about when you're telling your story. It's not meant to be prescriptive. It's not a kind of technical box ticking thing at all. It's just some domains that you might want to think about when you're looking at the totality, the rich case study of let's get remote services up and running, at say a regional or national level, but also, is this patient who's asked for a consultation with me, is it appropriate to offer him or her a remote consultation? So it goes at different levels. So if I start with the patient, if you like, with the reason why they want a consultation, so let's just start with that for the sake of argument. Of course, some conditions are going to be unsuitable. The patient, for example, has a gynecological problem and needs an internal examination for the sake of argument. You're not going to do that remotely. On the other hand, there are some conditions for which there's no particular reason why they shouldn't be done remotely. And some are suitable for telephone and some are not. And this all takes account of things like the clinical risk and the rate at which something's changing and all that kind of thing. But there's a whole area of research around the uncertainty associated with a request for a consultation. So that's the first domain. The second domain is the clinical relationship. So coming into the data that we have for Scotland, people would say, well, if I know the patient, you know, if this has been my patient for 15 years, I know Mrs. So-and-so, it's much easier to connect with them by telephone, and particularly. Then there's the patient's home circumstances and family circumstances. And this is the domain where we look at whether or not the person has digital connection at home, whether there's within the family somewhere the level of expertise to get that person connected onto an iPad or a smartphone or something like that, but also issues around digital poverty. So 10% of the patients we talked to or surveyed in Scotland was saying, I don't want a video consultation because my data package isn't good enough to support that. And then all sorts of things about access to material space in the home. You may find that you know, dad's okay, dad's got a study, dad's got a computer, but you know, mum and the kids are not allowed in there. So hang on a minute, who controls access to the consulting space, and is there privacy? Is there enough privacy to have a consultation? The next domain is the patient themselves, actually. You know, are they capable? Do they have any kind of physical or cognitive impairments that would make them not able to connect remotely? So it works both ways, actually. You know, if patient's hard of hearing, it might be easier to do a video consultation because firstly, they can turn the volume up, but also you can type into the chat and they can lip read. Whereas if you're in face-to-face, you know, you might be wearing masks and it might be more difficult. So all that kind of thing. And then linked to that domain of the patient is what's happening to support patients who are less digitally literate. You know, is there any training? Is there any help for those patients? Okay, so moving over within the PERCS framework to the organizational dimension, it's been shown time and again that innovative organizations are better at introducing technology. So what do we mean by innovative organizations? And they're often outward-looking organizations with good leadership, with clear strategic vision, you know, and also they've often got lots of other digital innovations that they've already introduced and evaluated, and they've got the setup for that. There's probably somebody in the organization who's quite keen on IT, all that kind of thing. And if you haven't got that, those preconditions, it's going to be harder to introduce. And going back to Scotland, this is one of the things that they did very well, is they helped organizations in both primary and secondary care to, if you like, get to first base in terms of digital maturity. Then another component of the PERCS framework is the technologies themselves. And again, if we look at the Scottish example of this, historically, there were some dreadful technologies, and we do write about those in the paper. They just didn't work very well. They were designed for a completely different purpose, and frankly, it all went pear-shaped when people tried to use them. But what they had been doing with the technology that was used for video consultations, they'd been working with the developer to refine it and tweak it. So it wasn't your beta version. It was pretty much a mature product. It was pretty simple, it was dependable, it didn't crash, it had basic reliable functionality, and people were quite familiar with it. So those are the kind of aspects: dependability, familiarity, and also the whole sort of supply chain thing, that it was available to people to to use. So that's the organization and the technology, and we do have a scale of digital maturity where organizations can assess themselves against that, or a researcher can assess them. And then the final component of the PERCS framework is the wider system: what's happening with policy, what's happening sort of outside that organization. Are the other organizations, down the road, across the street, are they doing stuff? Is there a sort of normative pressure on organizations to do this? Of course, during the pandemic, of course there was right around the world. So lots of stuff there. And then I suppose the other thing to say about the PERCS framework is we do talk about the kind of ethical quality pillars. What does good look like? What is a good health service? And so we come back to, I think it was Don Obedian's Quality 6, efficiency, effectiveness, safety, equity, timeliness, patient-centeredness, all those kind of things underpin the decision to introduce video or other remote technologies. They're not separate from your standard healthcare quality factors. Then there's clinical ethics, the whole ethics of the clinical consultation. You've got things like, autonomy and justice and privacy and confidentiality, the sorts of things we learn about as students. And then we've also got the ethics of looking after one's staff, looking after the planet, other things that we should be caring for as professionals. So there's a lot in the PERCS framework, and all it is a kind of aid memoir to pull together a really good, rich story of the remote consultation case that you're trying to write up.
So in closing, Dr. Greenhouse, what are next steps in your research, and where can our followers find you?
Well, we've just got some funding to do a study called Remote by Default 2. So Remote by Default 1 was a study we did during the pandemic where everything went remote pretty much. Unless you were being wheeled into the A&E department on a stretcher, you had to consult remotely. So we're now doing what we call RBD2, Remote by Default 2, which if you put my name into Google plus RBD2, you'll get our website. And we're just seeing what's happening as we come hopefully out of the pandemic. A lot of learning has happened. A lot of people, discovered remote consultations, particularly video consultations. What's going to happen now? Where is this going? Are we going to do all our chronic disease management by remote? Are we going to do pre-assessment by remote? Who's getting these face-to-face appointments that are now so much rarer than they used to be? So I think it's going to be a very interesting time. And yes, we'll be applying the PERCS framework to that.
Looking forward to it. This ends our interview. I want to say a big thank you to Dr. Greenhow for sitting down with me today. To read the full article and for other great articles like this, go to jmirpublications.com.